Let's talk about pain management and alternative therapies. Remember, pain is the fifth vital sign anytime you're assessing a patient. Substance P binds to NMDA receptors in dorsal horn or spinal canal to transmit pain. So opioids block substance P. These are morphine, hydromorphone, fentanyl, hydrocodone, oxycodone. Most patients' favorite is the hydromorphone and the oxycodone. But joking aside, whenever we have patients that have bedside procedures and we want something short-acting and with an immediate effect, we use fentanyl. So keep that in mind. Whenever patients have procedures and they're not allergic to fentanyl, that's the preferred medication. We also use fentanyl for the elderly because it clears the system faster, especially patients with delirium. And then another opioid is ketamine and methadone. They are NMDA antagonists and they block pain sensation. So pain is perceived by the brain. Mind-body techniques can help decrease perceptions like distraction, guided imagery, and meditation. Say, for example, a patient is having a procedure and you've given them pain medication, but they're still anxious. It's always good to incorporate guided imagery, like tell them, imagine their favorite place, their favorite beach, and just to get their mind away from the pain. And then also meditation. CNS depressants decrease the pain perception. So modulation, pain neurotransmitters are released to hinder the pain transmission. Patients have varied levels of neurotransmitters, and this is why different patients perceive pain differently. You can have a patient with their arm almost falling off from a traumatic incident, and they're laying there calm and expressing their pain as let's say 3 on a numeric scale out of 10, while a patient with a little slight, say, trauma to their finger, they're screaming and saying their pain is 10 out of 10. So just visualize those two. The neurochemicals of pain. So pain initiators include glutamate, which is a central. Substance P is central. Bradykinin is peripheral, and prostaglandins are peripheral. And then pain inhibitors include serotonin, endorphins, enkephalins, and dynorphin. Is the following statement true or false? Endorphins represent the same mechanism of pain relief as non-narcotic analgesics. This is a false statement. The reason being, endorphins do not represent the same mechanism of pain relief as non-narcotic analgesics. Endorphins release inhibits the transmission of painful impulses. They are endogenous neurotransmitters, structurally similar to opioids, and they are found in heavy concentration in the central nervous system. Physiologic basis for pain relief, pharmacologic interventions. Opioid analgesics act on the CNS to inhibit perception. NSAIDs decrease pain by inhibiting prostaglandin. Local anesthetics block nerve conduction. So for opioid analgesics, one of the reasons patients become very drowsy or sleepy is because of their they're working on the CNS. Neuropathic pain. The nerves are damaged with tissue damage. This is common in patients with diabetes and can be severe or mild. It presents as numbness or tingling, and if in fit, may increase in sharpness with ambulation. Gabapentin and clonidine may decrease the symptoms. Some of the factors that influence pain response is what's the patient's experience with pain. Do they have anxiety? Do they have a history of depression? What's their culture, their age, their gender? In my experience, women tend to tolerate pain more than men. Just think about it. So for this question, what is the time frame for pain that can be classified as chronic? The literature shows 3 to 6 months, and it's not one of these choices, so I need to fix this. So the answer in this case will be 3 to 6 months for the pain to be considered chronic. Opioid tolerance and addiction. This is a very common occurrence in the hospital. So the more patients take opioids, the higher doses they require subsequently. And so we always have to assess patients' history to find out if they have been taking opioids or if they are opioid naive. And so the dosing will be based on the patient's previous history with opioid. And then also we may use adjuncts, can be added to help with the pain management. So like, for example, especially patients with cancer, sometimes they get the opioids, and then they can also get anxiolytics like Ativan to help with the pain management. Chronic long-term pain. This video thing is doing it again. I'm gonna pause it and then restart it. Okay, I'm back again. So for patients with chronic long-term pain, we need to find ways to manage their pain, especially if they no longer respond to opioids, because we do not want to keep increasing the doses. As research has shown, cumulative doses doesn't necessarily improve the pain management response. So dependence occurs with tolerance. Physical symptoms occur when opioid is discontinued. So they can have withdrawal symptoms, say being shaky, they get anxious, and so we need to recognize this. And subsequently, in primary care or in pain management clinics, what doctors do is decrease the doses over a period of time and eventually discontinue the pain medication. So addiction is a behavioral pattern characterized by need to take drug for psychic effects. Even though the patient may not have pain, but they have this mindset that taking the medication or the drug will make them feel better, even though it's not for the intended purpose of pain management. Addiction from therapeutic use of opioid is negligible. Say, for example, a patient is admitted after a traumatic event, say a motor vehicle accident, and they are afraid that if they started on opioids, they might get addicted. It's important that we educate these patients that short-term use does not lead to addiction. So for our older population, they are more likely to have toxic drug effects and drug interaction. This is because the clearance of the drugs is impaired due to age, and many of them are opioid naive. So we always have to assess for that. Increased likelihood of chronic illness, may need more time between doses due to decreased excretion, metabolism, and increased fat tissue where pain medication is stored. And then also they're more likely to have GI bleed from NSAIDs. This is one of the reasons we avoid NSAIDs in the elderly. This is a geriatric pain medication. So some of the recommendations, like morphine, avoiding patients with decreased creatinine clearance, hydromorphone, avoiding patients with decreased creatinine clearance, and then fentanyl, especially the 72-hour patch. This is actually not recommended for the elderly patients because of the fluctuating levels. And then meperidine, I haven't seen this in the hospital for a while. It's contraindicated for treatment of pain, puts patients at risk for seizures. So pain relief dosing regimen. So PRN medications, this is given as needed. So the scheduling for PRN only without any scheduled medication. This is when pain is not present for more than 12 hours a day. That's when we schedule them as PRN. Routine administration around the clock or preventive approach for surgical and chronic pain. For post-op patients, it's actually important that we wake them up just to keep the levels up. That way they don't wake up in a lot of pain. This is very common on the surgical floors, even though we have the sleep order for patients for us not to interrupt, but this is important because if they wake up in a lot of pain, then they will not be able to participate in therapy, and will have a hard time managing their pain if it's too high. And then educate patients to take early before pain becomes severe, and then taper the doses when discontinuing. So for major procedures that require a lot of pain medications, especially IV or oral, we'll normally start the transition patients from IV medications to oral medications, and then eventually space them out before discharge. Here are some of the non-opioid analgesic agents. Acetaminophen can be given IV, orally, or per rectum, and the maximum per day is 4 grams, just to avoid liver failure. And the NSAID, the PO, topical, intranasal, IV. The only IV NSAID I've seen is the Toradol. And these are some of the side effects you might want to think about. Analgesic ceiling, this is what I talked about earlier. Increasing dose above upper limit produces no greater analgesia, and so we should avoid giving patients higher and higher doses with the hope of achieving pain relief, because it does not add to their analgesic management, if that's how we can put it. And then non-opioids do not produce tolerance or addiction. So opioids are pure agonists. These are morphine, oxycodone, fentanyl, and codeine. They're potent, there's no analgesic ceiling, and have several routes for administration. Often combined with non-opioid analgesic for relief of moderate pain, must be filled within 24 hours using a triplicate form, and cannot be called into a pharmacy. So say, for example, oxycodone. So Percocet is a combination of oxycodone and Tylenol. And so whenever you treat medicating a patient who has a separate Tylenol order, you have to keep in mind that there's Tylenol in the Percocet, and it can affect or go beyond the 4-gram recommendation for the 24 hours. So just be aware of that. In most cases in the hospital, they prescribe oxycodone by itself and Tylenol by itself. That way we can monitor how much Tylenol they take. And at UC Davis, whenever you're approaching the 4-gram limit, the rover will not let you administer any medication with Tylenol if it's been over the 4-gram. So always pay attention to your hard stops on the rover before you administer medications. Adverse effects of opioid analgesic agents include respiratory depression, rare in acute pain, because patient will be in a lot of pain, and so they are totally focused on the pain, and the vital signs can be altered. Say, for example, if patient is in a lot of pain, they'll be breathing fast, their blood pressure will be elevated, and so this is not an issue whenever patient is in acute pain. And then the other thing we have to worry about is sedation. I don't know if you guys have taken care of a patient with sickle cell. These patients get high levels of opioid analgesic agents, and for the most part they are sleeping most of the time, and so you have to be aware not to give too much medication, and then also monitor them for respiratory depression and sedation. For those that are on PCA, we now have a CO2 monitor attached to the PCA to make sure that it's monitoring the CO2 levels, and then also the respiratory rate. Whenever the respiratory rate falls below 8, the PCA stops giving the patient a dose until the patient wakes up and the respiratory rate goes up and the CO2 levels drop. Another thing is nausea and vomiting. We normally give either Zofran or any other antiemetic to prevent that. And then constipation is a very common occurrence of opioid analgesics, and so for the most part, patients on opioids, we also give them either Coles or Miralax or any other medication that will soften their stools. And then a very common thing, especially in sickle cell patients, is pruritus. And so just remember they're taking so much opioids, and then whenever they're itching like that, we give them Benadryl, and then Benadryl also makes them sleepy. So this is why it's very important to keep an eye on patients that are on medications that can potentially make them overly sedated. Administration analgesic dosing. Dose of one analgesic that is equivalent in pain relieving effects compared with another analgesic. Say if you go from IV to oral opioids, say the dilaudid IV to oral dilaudid, or IV morphine to some other oral opioid. So this is something that pharmacy can provide recommendations. And then permit substitution of analgesics in the event that a particular drug is ineffective or causes intolerable side effects. Equianalgesic charts are just guidelines. Follow the healthcare facility pain protocols. Like I said, UC Davis. And I keep saying UC Davis because that's what I'm familiar with, and that's where I'm currently practicing as a nurse. And for the most part, if we're having issues managing patients' pain, a pain pharmacist is consulted, or the pain management team, which includes a doctor, will be involved in coming up with a plan for pain management for patients. Okay, here's a conversion chart that you guys can review. So clonidine decreases central and peripheral adrenergic transmission, chronic pain and non-cancer pain, acute postoperative pain, peripheral neuropathy, antiemetic, migraines, gastroparesis, and bipolar disorder. So PO peak is in 1 to 2, and it stays for 12 hours. The patch onset 2 to 3 days, up to 7 days. And then there's epidural and intrathecal. Monitor for hypotension, bradycardia, and sedation, dry mouth, constipation, and transient hyperglycemia. Just remember, anytime a patient has clonidine ordered, be sure to check their blood pressure before you proceed. I'm going to finish this slide even though this thing just popped up, but I hope you guys can look past it since we already reviewed that bullet point. And the clonidine also, remember, can potentiate narcotics. Beta blockers may cause rebound hypertension when withdrawn and may have increased risk for bradycardia. Additive effect for hypotension with nitrates, and then do not substitute between clonidine products. I'm gonna pause and get rid of this thing before I proceed. Okay, I'm back. Hopefully it doesn't happen again and we can get through this. So gabapentin mechanism of action is unknown, but it's used for peripheral neuropathy, seizure, postherpetic pain. PO peak 2 to 4, duration is 8 hours. For sustained release, peak is 5 to 8 and duration is 24 hours. The most commonly dosed thing that I have seen in the hospital is mostly 3 times a day, which is every 8 hours. Adverse reaction includes suicidal thoughts, depression, dizziness, sedation, hypertension, weight gain, and rhabdomyolysis. Fentanyl works in the CNS to block perception of pain, breakthrough pain in cancer patients, pre- and post-operative pain prior to invasive procedures, has a short half-life. For chronic pain, patch can be prescribed, but this has been known to be a little bit dangerous because of its disposal. And if you guys can remember, a few years back, people were taking oxycodone that was laced with fentanyl that led to a lot of fatalities in the community. So just be aware of that. I also talked about fentanyl being the drug of choice for doing a procedure at the bedside. So just remember that. IV onset is 1 to 2 minutes, peak is 3 to 5 minutes, and then duration is half hour to 1 hour. Patch onset is 6 hours, peak is 12 to 24 hours, and then the duration is 72 hours. So that's 3 days. Use in caution in the elderly and severe renal and liver impairment. My recommendation is not to use the patch at all in the elderly. Adverse effects include apnea, bradycardia, hypotension, and CNS depression. It also potentiates opioids and CNS depressants. Calcium channel blocker, ketamine, macrolides may increase risk of respiratory depression, just so you're aware of that. Here is the wonder drug. So Narcan is a very good drug to have, because if patients have taken too much of all the opioids we just talked about, this is your magic drug that will wake the patient up. This has happened to me once. As a nurse in my career, I've only had to give it once. We had a patient that was complaining of pain, and we kept pushing IV Dilaudid. Luckily, the doctor was on the unit, and when we gave the last dose of 0.5 Dilaudid, the patient's breathing significantly decreased. They went pale and became diaphoretic. We gave the Narcan, and patient threw up. Luckily, I was not in the line of fire. So just be aware when you're waking up patients using Narcan. They can either wake up and hit you or throw up in your face. So just stay on the side if you can. Lately, there's a nasal Narcan that's provided to, it's a spray that's provided to the homeless population, just so in case of an overdose incidence. So the IV onset is 1 to 2 minutes and duration is 45 minutes. IM onset is 2 to 5, duration is 45 plus. Intranasal onset is 10 minutes, duration is unknown. It can cause acute withdrawal symptoms in opioid-dependent patients. Adverse effects include ventricular tachycardia, hypertension, and nausea and vomiting. This is real, the vomiting part. It reverses analgesia, and so just imagine a patient that's in a lot of pain. You've medicated them, and then they have a reaction, and then you give them this, and it reverses it right away. This is the normal dosage, and then may need to repeat in 30 to 45 minutes. So some of the routes for these medications, like I mentioned, fentanyl can be administered transdermally, and it's every 48 to 72 hours. Then parenteral routes, best for breakthrough pain. Intraspinal delivery, epidural, highly potent, smaller doses necessary. Nerve block pumps, on cue, fixed flow pumps. Then there is also patient-controlled analgesia, which is the PCA, as you know it. Epidural infusion, smaller doses required, pain control with decreased sedation, opioids, anesthetics, and others. So with epidural infusion, one of the things you want to make sure you assess is the site, make sure it's intact, and bedside nurses usually don't mess with this. Anesthesia is responsible for managing the site, but you are required to assess and report any abnormalities, and then also make sure you check the patient's sensation distal to the site of the anesthesia, of the epidural, I'm sorry. So morphine, that's the onset, hydromorphone, fentanyl, clonidine, and ketamine. Bupivacaine blocks sympathetic nerves. Monitor continuously first 20 minutes, then every hour for 12 hours, then every 2 hours, after 24 hours, every 4 hours. Check dressing is intact every 4 hours and do not change. Like I said, this is anesthesia's area and you do not want to cross their line. Also, I was going to mention that if the patient is bedbound, be careful whenever you're moving patients, repositioning them to make sure you visualize the line up to the pump. That way it doesn't get caught in the bed sheet or anything like that, because if it dislodges, then it is a big deal. There is always a number for anesthesia available to page them in case something goes wrong with the line. That's a good one. You can review that. Oh, there you go, nursing management. So monitor sensation, pain level, and follow protocols. Question anticoagulants. For the most part, patients on epidural, they usually have a catheter. Check site with initial assessment. IV line is yellow. I'm not sure if this is the case everywhere else. No injections into the line, no matter what. Only pump. So for opioids, assess respiration, sedation, pruritus, nausea and vomiting, urinary retention. Anesthetics, assess motor and sensory block, bradycardia, hypotension, systemic toxic effects, secumoral paresthesia, tinnitus, tremors, and dysrhythmias. Intraspinal infusion, percutaneous 2 to 4 days, surgically placed months. Can use smaller doses than epidural. 1 milligram MS versus 10 milligram MS, all infusion preservative free. Clearly mark the infusion line. So complications include dislodging, like I was saying. Make sure you visualize the line and doesn't get caught in the bedding. Catheter migration, infection, pain during injection. The nerve block pump on cue. I have never seen this at the bedside, but let me rephrase that. I've seen it, but I've never had to manage it. So the catheter is placed intra-op near surgical site. Anesthetic is slowly and continuously delivered for up to 5 days. Better pain control with fewer narcotics, increased patient mobility. Do not squeeze pump. Ensure tubing is not occluded or kinked. Assess site and pain level. And then if patient is going home with it, I think it's important to provide extensive teaching. Okay, you can review that. So here's some of the examples of alternative therapies used for pain. So surgical pain, Reiki, acupuncture, hypnosis with relaxation, guided imagery, distraction, and therapeutic touch. For muscle pain, there's massage, TENS machine, fish oil, and herbal creams. Cancer pain, aromatherapy, acupuncture, relaxation, and guided imagery. Mistletoe extract, acupuncture is mentioned twice. Stress reduction class, music therapy. Psycho-emotional pain, hypnosis, aromatherapy, massage, reflexology, and prayer. So you can review this. And before I end the video or the presentation, be sure to understand visceral pain, how to describe it, and chronic pain, neuropathic pain, and breakthrough pain. And so whenever a patient is complaining of increasing pain, even though they are on a form of pain management system, be sure to assess using your PQRST. And like I mentioned before, what medication you use for bedside procedures, and what kind of alternative therapy can we use to manage pain in patients with anxiety. Thank you, and I hope we'll have some lectures in person soon once this craziness is over with the COVID. I'm looking forward to meeting all of you in a classroom setting, and hopefully get to see some of you in the clinical setting once the we get back to normal operations. I'm always available by cell phone. The number is 916-217-3814 if you guys have any questions. And then also if you have any comments about the lectures. Also, I wanted to recommend that you all review your you review the goals, the objectives for each topic. That can be a good study tool for your tests. Okay. Bye. I hope you stay safe.